respiratory tract infections. This webinar is brought to you by Hetero Healthcare, an innovative pharmaceutical company. Hetero Healthcare, the journey began in 1993 with 30 years of excellence, 36 state-of-art manufacturing facilities. Hetero Healthcare has 300 plus products in portfolio and presence in 126 plus countries. Hetero Healthcare has 21,000 employees globally and is the largest closely held pharmaceutical company in India, and it's among the largest manufacturers of ARV, APIs, and FDFs in the world. Hetero Healthcare has Asia's largest API manufacturing facility at SCZ Complex, Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation, and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Hetero Healthcare, the pioneers in antivirals, offered oseltamivir, favipiravir, and remdesivir to the patient, because of which, in August 2020, Hetero Healthcare received an award of Pharma Excellence for COVID drugs. Today's webinar, Rational Approach to Viral Respiratory Tract Infections. We have got moderator Dr. Pramod Jog and speaker Dr. Keyur Mahajan. Dr. Pramod Jog sir is MD, MN, AMS, FIAP, FIC, MCH, PG Diploma in Pediatric Infectious Disease. Sir is best performer at ADVSC France 2011, MA in Sanskrit, proficiency in French and Spanish, Director of WOM 18, Professor of Pediatrics at DY Patil Medical College, Pune, National President, Indian Pediatrics, IIP 2016, Standing Committee Member, International Pediatric Association, IPA, Steering Committee Member, GAVI, CSOSC, Standing Committee Member, ASPID, Asian Society of Pediatric Infectious Disease, Consultant Pediatrician, MediPoint, Jupiter, UNICEF, Member, Maharashtra State Pediatric COVID and Disease Task Force. Once again, welcome, Dr. Zog. Dr. Keyur Mahajan sir is MBBS DNB Pediatrics Pune. Sir is, in addition, sir is Diploma in Pediatric Infectious Disease from Oxford, UK, and is Pediatric Infectious Disease Consultant, Pune. Welcome, Dr. Keyur. And with this brief introduction, I'll hand over the session to Dr. Pramod Jog. Over to you, sir.
Thank you. I will just share my screen and
yes, sir.
Okay, yeah. I hope the screen is visible and my voice is audible. Okay. Okay.
Can you? Screen is not visible currently, but voice is audible. Yes, now it's visible. Yes.
Okay. Now
it's visible.
Am I audible?
Yeah. Yes, sir. Yes.
Can you hear me?
Yes, sir. Clearly.
Okay, very good. So, my dear friends, today we are going to discuss a very important topic, that is rational approach to viral respiratory infections. As you all are aware, viral infections are very common in pediatric practice, and viral respiratory infections are the ones which are very, very, very common, and almost I would say it's the bread and butter of a practicing pediatrician, and they account for the majority of the outpatient visits, the emergency room consultations, and hospital admissions, and particularly in children under the age of 5 years. They contribute significantly to antibiotic overuse and school absenteeism and parental anxiety and healthcare costs. And seasonal surges and post-pandemic shifts have altered the patterns of presentation of viral respiratory infections. So, one should be aware that the viral respiratory infections in pediatric practice today form the majority chunk of pediatric practice, and they vary from very mild to very severe form. And as I told you earlier, our colleagues are unable to differentiate viral from bacterial, and that is why they land up in prescribing antibiotics. Now, this is one dilemma or a puzzle which I have not yet an answer to. You know, whenever one person or a doctor or a pediatrician or a physician is in puzzle, he tends to give antibiotics. He doesn't think of prescribing, either an antiviral or just not prescribing anything. But whenever he is in doubt, he says, "Oh no, let me prescribe some antibiotics." So he continues to prescribe antibiotics like amoxicillin when they are really not necessary, because as I told you, 90% of the viral infections are seen in case of respiratory infections in children, and time is the only solution. So we used to hear that if you treat the cold, it will be all right in a week. And if you do not treat, it will take 7 days. The meaning is the same. Ultimately, it takes 7 days. And a general course of each viral infection is almost the same. And during today's discussion, we are going to discuss various aspects of these viral respiratory infections. These are not usually discussed, and usually, people end up discussing about common cold and say, oh, it's very common. What is to discuss in that? But there are many minor things which we need to discuss. And Dr. Keyur, if you are with us, I would just like to ask you as to after this COVID era, do you think that the pediatric viral respiratory infections have changed their nature, or what is your opinion in general after COVID? What has happened to these various viral respiratory infections?
Sir, after COVID, what we have seen that usually pre-COVID era, so we used to have viral infections, and usually the trend is the fever starts, then cough, cold, rhinorrhea, and fever usually used to last by 3 days, 4 days. So we had that notion that fever, if it is viral, it will last for 3 days. We used to counsel the patient that, ठीक है, viral है, 3 दिन रहेगा, and it will settle down. Now, what is happening that post-COVID era, viral infections are not settling down in 3 4 days. The duration of fever has increased, the severity of fever has increased, prodromes have increased, associated body ache, myalgia, so other symptoms have increased. So what strikingly difference is that the duration of illness, which used to be shorter pre-COVID era, so the duration of illness has increased. So that is the most important factor which has come along. And of course, people are more aware of viral infections. Previously, we have to explain them this is viral infection, you don't need antibiotics, this is viral. Now, because of COVID, there is surge in knowledge of people. So now they understand the concept of viral infections. So it's easier for us to counsel also. But of course, yes, the duration of fever, severity of symptoms, post viral after effects are also longer duration, like the myalgia, weakness, fatigue, that has also increased. So those are the changes.
Sure, sure. And I'm sure you'll agree with me that during this flu as well as this COVID pandemic, we have witnessed those problems which come up after 5, 6, 7 days in the form of a cytokine storm. So people
Yeah.
are now aware that, viral infections are not that, simple, and
Mm.
sometimes there could be some serious complications. So the awareness in general, I'm sure you would agree with me that has definitely increased. So with
Yes.
this, I will just put a small little case where a 6-year-old girl attending a daycare presents with rhinorrhea and daytime cough for the last 8 days. She had fever for 2 days and her appetite is poor. And on physical examination, there is clear rhinorrhea which is present, and rest of the examination is unremarkable. And this is obviously a case of common cold. So I would just like you to tell us as to which are the viruses which most commonly cause respiratory infections in children.
So what the most common cause of upper respiratory infection are RSV virus. Then what we see are the adeno, then different rhinoviruses, then different varieties of coronaviruses, influenza viruses, parainfluenza viruses, and human metapneumoviruses. So these are the different varieties of viruses. The commonest is rhinovirus, and which is the most common cause of upper respiratory, that common cold. And then other viruses are there. Usually, like we all know that these viruses like RSV, metapneumo, influenza, they may progress to low respiratory tract infection also. So, but these are the common viruses which usually presents with the viral infection, upper respiratory viral infections in children.
Sure. And I'm sure you'll agree with me that some viruses, they are primarily respiratory, like adenovirus, but
Yes.
many times, they present with pharyngoconjunctival fever, and some of them, they may have, mesenteric adenitis and, some other, problems which are not necessarily
Right.
respiratory.
Fact,
And
adenovirus is very difficult, sir. If it may mimic a bacterial infection also. So prolonged fever, high CRP, counts variable. So many a times it happens that we do treat adenovirus as a bacterial infection because it may mimic bacterial infection. So it poses challenges in diagnosis.
Sure, sure. So there are some agents which are primarily associated with common cold, like the human rhinovirus or the coronavirus. And of course, some of
Yes, sir.
them can come with wheezing and bronchiolitis also. And there are some
Yes.
agents which primarily are associated with other clinical syndromes that also cause common cold symptoms, as we discussed about, some of them which could, later on present with some different presentation. So one should remember that some of these may appear simple, like, only mild fever with cold and cough. But influenza is, I would say, the father of all those influenza-like illnesses. And that is the one where one may get severe headache, and then the child can have myalgia, weakness, to an extent that, an older child also probably is lifted up by, his parents and brought to the clinic. That's because of severe weakness. And during the periods of epidemic or season of influenza, one should be quite aware that it's possible that we are facing a child with influenza, and one has to be careful because that's the only viral condition which is treatable with oseltamivir, and that's why one has to be on lookout for some of these important symptoms and signs. So, as regards this common cold, which I said usually is not discussed, one must remember that a child on an average gets about 6 to 8 colds per year, and about 10 to 15% of children get about 12 infections per year, and the incidence of the illness decreases with increasing age. Finally, in adulthood, we have about 2 to 3 illnesses per year, and children who are in the daycare during the first year of life, they suffer 50% more cold than children who are cared for only at home. Obviously, in our day-to-day practice, we see that children who attend the daycare centers usually come to us more often. And then the parents are to be told that simply because, so many children come from different areas of the city, they bring different kinds of viruses. And, this leads to what is called as back-to-back viral infections. And these children may have scratchy, sore throat, may have nasal obstruction, rhinorrhea. In two-thirds of children, you can have cough and the cold, which may last for about 1 to 2 weeks, along with fever and constitutional symptoms. And of course, sometimes the color or the consistency of the secretions changes, but it does not mean that it indicates sinusitis or bacterial superinfection. Particularly, the turbinates, the nasal terminates, may appear swollen and erythematous. So, all this information related to the common cold is extremely important, and we need to treat these children with supportive care in the form of you know adequate oral hydration, warm fluids, saline instillations, and cough and cold products need not be used, particularly in very young children. Okay, and antibacterial therapy is also not indicated because these are all viral problems. I have put up the photograph of Satya Sai Baba in my OPD, and you will ask me as to why. The logo of Satya Sai Baba is Shraddha or Saburi. So for all viral infections, the only medication is Shraddha or Saburi. Believe in the doctor and keep patience. So by 7 days, most of these viral infections, they automatically get controlled. And some of them may require some first generation antihistamines and vitamin C, guaifenesin, inhalation of warm unified air. These are many a times the ones which act like a placebo for the treatment of cold symptoms. One thing is that there are some products in the market which contain menthol, okay, and they are sold as rubs, vapor rubs, and all. So they are better avoided because there are some children who are sensitive to menthol and some other products and can create problems. So it is better that these children are managed conservatively. And Dr. Keyur, in case if you could just explain this course of uncomplicated viral URIs with the help of this particular graph, it will definitely help our listeners. Where the x-axis is showing the days of illness and the y-axis is showing the severity of the illness. So, what do you think this graph depicts?
Yes, this graph depicts how the viral infections behave. So the difference between the viral and bacterial infection is the onset of fever, how the fever starts. So typically in viral fevers, the parents say the child was okay in the morning and suddenly in the evening he had a high grade fever of 101, 102. So the sudden surge in fever, which is the typical of any viral infection. So that we can see that orange color or red color, the graph is of for fever. So what is seen here is in any uncomplicated fever, viral URI, the fever spikes on day one, and usually the spikes remain in high grade for day one, two, and it gradually comes to by day three and four. But now, as we discussed, that this graph has changed a little bit. When the normal viral URI is also the fever duration of 3 days is now not a common dictum. Now the fever lasts little bit longer. It may last up to 4 or 5 days also. But yes, the onset of fever is sudden onset. So that is again, and then the respiratory symptoms comes gradually. That means on day one, there may not be a running nose or cough or cold or the symptoms. So on day one, if you see the child, you may be not sure whether it is upper respiratory tract infection or adenoviral infection. But on day two, three, the other symptoms also comes. So that comes later, or respiratory symptoms. But the fever, and as seen, the fever settles down, but these respiratory symptoms linger a bit longer. So cough may be there for 7 days, 10 days, 14 days, cold may be there. So we will have to counsel them, because the commonest problem with these smaller kids are they keep coughing a lot, and they keep coughing for long duration. And the parents are anxious कि खोखला अपने cough is not going up. So we have to counsel them that this is viral infection. Fever will be high grade. It will stay for 2 3 days. Then it will start coming down. So you will have to keep hydrating the child. The cough cold will be there. It will stay longer. The duration may be more than 7 days, 10 days, 14 days. So the counseling parts is very important in any viral infection, because the treatment is symptomatic. But so if any patient comes to our OPD, 20% is the drug, 80% will be counseling. So we have to counsel them properly so that the parents will not get panicked due to the severity of fever, duration of fever, and duration of respiratory symptoms. So this graph depicts that.
Thank you. This is very important. And, when a child comes to you with fever, cold, and cough, if you tell them this particular course of uncomplicated viral URI, then the parents, are not panicky in the first 10 to 12 days. Otherwise, if you do not explain this fact that the fever will subside and then the respiratory symptoms will start and linger on for a long time, then they will keep calling you, every day or two saying, sir, child is not improving, sir, child is not improving. So tell them that this is usually what happens in a viral URI. And whenever they come to you, say, some parents come after about an hour, an year or so. Sometimes they come for second opinion. Sir, for the last 1 year we have been consulting such and such a doctor, but he is treating every time the child. After 1 month again the child is getting the same problem, after 2 months again getting the same problem. So ask them, does it happen that the child starts getting fever of abrupt onset and goes after disappears after 2 to 3 days, and then starts getting respiratory symptoms which last for about 10 to 12 days? Yes, yes, yes. They say, sir, yes, you're absolutely right. Everything it happens like this only. So then they know that what you are telling is something truth. So then tell them that up to 10 to 12 episodes like this are normal in children, and then they are reassured, provided the weight gain is normal, provided the growth chart is normal and the child is gaining normal weight, and the child in general is not affected as regards the appetite and playfulness and sleep, etc. Okay, so with all this, now we may convey an impression to our listeners that it's all very, very simple, but it's not that so. So Dr. Keyur, what do you think are the red flags which suggest severe disease or complications in a child who has presented with so-called viral infection?
Yeah, red flags for any viral infection are like if the child is having poor oral intake, you have to monitor the hydration of the child, how the severity of fever is there. Normal course is, as we suggested, the fever starts decreasing by day 2 3. The fever is persistent, the poor oral intake is there, tachypnea is there, that means respiratory rate is high. If the cyanosis, so these are the symptoms. So we have to ask parents to keep monitoring their hydration. Hydration is the first part. If the child's oral intake is good, hydration, oral liquid hydration is good, urine output is good, then it's okay. Second part we have to ask them to monitor is how the child's breathing. If the breathing rate is high, if child is having distress, like he is using extra muscles while breathing, so we have to explain them that these things have to be monitored. And if the fever is not subsiding, then again that thing has to be monitored. So these are the few red flags for any respiratory infection. We have to ask them to monitor at home. And for any viral infections, you have to ask them to come for follow-up. See, if you are diagnosing it as a viral infection and you are not giving any antibacterials or any treatment for that, you know, asking them, see, this is viral infection, this has this common course, but all infections will not follow that course. Okay, so if you counsel them ki हाँ 2 3 days में fever settle हो जाएगा, cough cold will be there, then they will be a bit relaxed. So but you have to counsel them that you have to monitor these things. You have to show me after 24 or 48 hours of follow-up, and if there is any worsening of symptoms, then you have to treat appropriately. Because again, whether to treat, whether if it is a viral infection also. So as sir we were discussing, there are categories of viral infections with how, when to start treatment, when to start antivirals, when not to start antivirals, when to admit. Okay, so these things are to be seen. So any viral infections, you have to ask them to come for follow-up in OPD after 24 to 48 hours and ask them to monitor certain these red flags, sir.
Sure. So if I get you right, when the child comes to the OPD, there are certain things which the doctor needs to observe. And even if the child appears apparently okay without any red flags, see that the child is asked to come for a follow-up after 4 or 5 days, because some of these infections might have a biphasic presentation, as we saw in the cytokine storm stories, where after 3 4 days, 5 days, the child would probably come with worsening of the symptoms. I usually do one thing after examination is over. I myself ask myself, and I use the mnemonic stop. So I say, Dr. Jog, stop. So what is that stop? So that is sensorium. As Dr. Kayur said, the child, whether he is lethargic, that T in that short form stop stands for tachypnea or temperature which is very high. Then O stands for hypoxia, that is oxygen, and P stands for perfusion. Okay, so if the child has deranged sensorium, has tachypnea, has hypoxia, or impaired perfusion, then usually I have instructed myself that stop. So before you proceed with anything, explain to the parents also. See, the child doesn't appear to be okay, and then it's better that you either keep the child under observation in the hospital, or whatever I tell you, please follow my advice. So this mnemonic stop will probably help our colleagues to identify some of these red flags. Now, this child which we discussed has improved for a week and again developed high-grade fever with thick mucopurulent nasal discharge. And whenever it happens after a week or 10 days, then one should always think of acute bacterial rhinosinusitis. And this can present with either, nasal congestion, rhinorrhea, or cough of duration of more than 10 days. That means, the parents, they call you or they come back after 10 days, sir, you gave all those medicines, antihistaminics, antipyretics, but the child is not at all normal. So after 10 days, stop thinking that this is simple viral and, think of something else. If the temperature, if it's high for 3 to 4 days, and now there is purulent discharge from the nose for 3 to 4 days, or there is return of symptoms after initial resolution, or there is new or recurrent fever, or increase in rhinorrhea, or increase in cough, one should suspect acute bacterial sinusitis. This is something which is often missed, because parents also feel that, okay, now 5 to 7 days are over, child will recover, and they wait for 10 days, 14 days, 21 days, and later on they say he's not still recovering, what to do? Then they come to the doctor, and at that time the diagnosis of acute bacterial sinusitis is made, but then that acute has either gone into subacute or chronic. Of course, there are some bacteria. Remember, sinusitis in majority of the cases now is bacterial, and there are typically three bacteria which we always discuss in the respiratory tract. These are Streptococcus pneumoniae, Haemophilus influenzae, and Moraxella catarrhalis. So these are the ones which produce most of the bacterial infection in the upper respiratory tract. We are not going to discuss bacterial infections today, so we'll just cut the story short by saying that the ideal treatment for these cases of sinusitis, it's in the form of amoxicillin or amoxiclav, depending on the clinical scenario. And let us proceed to the second case, where there is a 6-year-old boy with fever, throat pain, and vomiting, and child has swollen red tonsils and tender lymph nodes. Dr. Keyur, what do you think could be the diagnosis in this child?
Yeah. Child is having fever, throat pain, and swollen red tonsils, tender lymph nodes. So this presentation can be both viral and bacterial presentation. So we'll have to look actually how the things are progressing. But if the tonsils are red, exudates are seen, and typical clinical picture is there, then we will diagnose it as acute tonsillopharyngitis, and we will treat accordingly. But it's important to differentiate between viral and bacterial. Okay, so that is the crux. So whenever 80, see what we see in our OPD, almost 50-60% patients are of upper respiratory tract infections. Out of those, 80% are viral, only 10-20% are bacterial. So treatment differs. So because if you are diagnosing as a bacterial infection, the problem is that what commonly is done, that any antibiotic is prescribed routinely for 5 days. So we need to keep in mind that if you are diagnosing it is an upper respiratory bacterial infection, as sir has shown in previous slide, the minimum duration of treatment for any bacterial upper respiratory tract infection, any kind of, be it pharyngitis, be it sinusitis, be it otitis, you have to give it for a little bit longer duration for 10 to 14 days. So differentiating between viral and bacterial is important. Sir has rightly shown that viral, there will be more of a coryza, cough, associated other mucosal involvements. Other mucosal involvements in the form of eyes, there may be conjunctiva, other mucosal involvement in the form of intestine, there may be diarrhea, and again, the rash may be there associated with some viral infections. What we can see in bacterial infections, most common is streptococcal pyogenes, as sir has shown, and the symptoms, the cough, the presence of cough, absence of cough usually is more indicative. If the cough is present, rhinorrhea is present, it's more likely to be viral. If the cough is absent, but throat pain is more and fever is there, but the predominantly cough is absent as compared to this complaint, that as compared to the throat, what we see actually. So that again goes more into the bacterial infection. So we can see exudates, we can see tonsillopharyngeal inflammation and palatal petechiae and tender cervical lymphadenosis. Scarlet lentiform rash may not come altogether initially, it may come later. So on initial presentation on day 2, 3, so when we have to differentiate whether this is viral or bacterial, so presence of cough, cold, absence of cough, cold, helps us to majorly. It's not a dictum, but it majorly helps us. Okay. So again, sir, the sir has rightly pointed out. So there are different scoring systems. So to decide whether this is bacterial or viral, and as sir rightly pointed out, if it is temperature, no cough, again, you can see here, the absence of cough has given a 1 point. Then lymphadenopathy, tonsillar swelling and exudates, and the age matters. Okay, so depending on these different criteria, Centaur's criteria, they're modified Centaur's criteria. So depending on that criteria, whether the bacterial infection is there or not. So this is the maxillary decision rule. In depending on the number of score you get, the chances of having bacterial infection increases. More the score, more the chances. So you have to keep these things in mind while diagnosing a patient and giving appropriate treatment.
Sure. And Dr. Keyur,
And-
as you have
yeah.
said, yeah, you can just elaborate about the dosages and the duration of therapy in such cases whenever you suspect bacterial infections. Yeah.
Yes, sir. Yes, sir. As we discussed, any upper respiratory tract infection requires 10 days. We might be thinking that protocol say lower respiratory tract infection requires 5 days and upper respiratory requires 10 days. Why it is so? Why upper respiratory tract infections, bacterial infections need more duration of treatment? Because there is biofilm formation in the upper respiratory tract. The bacteria remains there in a biofilm and it stays there for longer time. So eradicate that bacteria from that biofilm, we require longer duration of treatment. So that's why standard protocols mentioned for lower respiratory 5 to 7 days are enough, but for upper respiratory you need longer.
Sure.
So as mentioned, is the drug of choice, 40 milligram per kg per day, and it can be divided into 2 doses, 10 days. And if the child is not responding, you can go to amoxiclav also. And other drugs I have mentioned. But remember that the duration of treatment should be longer.
Very
Now,
good.
azithromycin you can use, but nowadays most of these strains are now becoming resistant to azithromycin. So we are a little bit skeptical for using azithromycin for upper respiratory infection, and we rather prefer amoxiclav or amoxicillin preparations.
Yeah. So what one should remember is that even though it is tonsillopharyngitis, many of our colleagues feel that, oh, the throat is red, and immediately they put down, some antibiotic through their pen, which is not right because red throat is not bacterial. Remember, even in tonsillopharyngitis, 70% times it is viral. Only 30% cases is bacterial, and in those, that Streptococcus pyogenes is the organism, which is the most common organism, bacterium, which involves the tonsillopharyngeal area. However, remember the percentage of bacterial tonsillopharyngitis is only 30%. In general, remember that sinusitis and otitis are bacterial, and rhinitis and tonsillopharyngitis are in majority of the cases viral. Okay, and of course, we'll come to some pictures wherein you can see there are children with some oral lesions. So, Dr. Kevir, will you like to say a few words about these two pictures so that I will project the diagnosis once your description is over, so that our colleagues would understand. Maybe you can mention about the lesions in the oral cavity and in the lips and the angles of the mouth. So, what do you think? These two pictures are depicting. Okay. Yeah. Probably.
Yeah,
Yeah.
yeah. So here we can see there is crusting at the angle of mouth. Here we can see the lesions on the lips also and on the palate also. So this may be herpetic, herpes labialis and herpetic. Yeah, you pointed out herpes gingivitis. Because you see, if it is a bacterial throat infection, there is no reason to come lesions on the hard palate or lips or external angle of mouth. So these lesions on lips, angle of mouth is typical of herpetic gingivitis. Yes.
Yes.
So yes, and we may confuse with this. So we should be very clear. If the lesions are on lips, angle of mouth is involved, and there is crusting of lesions, and this typically indicates that this is herpes. And this is herpangina, as Sir rightly said. The lesions are a little bit on posterior aspects, and the lips are not involved. So this is herpangina.
Right. And herpangina, as everyone should know, this is related to the Coxsackie viruses, and these lesions are, quite painful. And many times, children come with, combined lesions, which involve the lesions like the hand, foot, mouth disease, along with this. Am I right, Kayur? Sometimes
Yes,
they.
yes, sir.
Yeah. Yeah.
So they
Okay.
actually present like a severe throat pain. Means they come with fever and difficulty in swallowing. So
Right.
complaints are usually like that. Ki, sir, his child is having high grade fever and he is not eating anything. He is having difficulty in swallowing. He may be having drooling also. So
Sure.
because the parents usually don't see throat inside. Okay.
Right.
So what they complain is the fever is high grade and he is not swelling anything. Okay, so we will have to see proper throat examination. The throat examination is very important for any children with a fever. So our actually PG teacher used to say that if you don't do throat examination or upper respiratory tract infection in exam, you will get fail. So we should have proper tongue depressors in our OPD, because what happens that many a times if you have disposable tongue depressors, not you don't have disposable tongue depressors and multiple usual steels tongue depressor what happens that number of tongue depressors are not sufficient. So what we do in first 2 3 patients we will see, later on we don't see. So it's better to keep disposable tongue depressors. These are easily available and very cheap. So please make a habit to see a throat in every patient of fever and upper respiratory infection like when you see. And yes, in Arpangina, the small painful red blisters with white gray centers, and child is fussy, child is not eating, high grade fever, and as sir rightly said, it is viral, mostly enteroviruses. Coxsackie is very common. And again, as we see more patients of hand foot mouth disease, now so in that other lesions on the body also can be seen. And we need to differentiate this because there is no need of antibiotic, because antibiotic will not work here. So we need to differentiate between these lesions. As I rightly said, this is herpetic, this is herpangina, and there is no need of antibiotic, just symptomatic treatment is needed. So that should be differentiated. Yes.
Sure. So, whenever you find ulcers on the throat, remember these are viral and no antibiotics are required. Now, in your routine pediatric practice, Keyur, there are certain things related to the testing for the viral etiology. And in brief, I would just like you to tell us as to when should we test for viral etiology, because we say that it's okay, it's viral, there is cold, cough, and fever. What extra are I going to do? So, when do you test, these nasopharyngeal swabs for the viral etiology?
Usually in OPD, the testing is not needed. If you are managing patient in on OPD basis, then there is no need to test. Okay. If you are thinking of starting antiviral on OPD basis, then there is no need to test. You can start straight away. So there are different categories, category A, B, C, and a category are milder versions. Those need only OPD based symptomatic treatment, not even antiviral also. Category B are little bit in between of category C and B, A. Those who are having high grade fever, those who are having prolonged symptoms, those who are having high prodromal symptoms. So those children we may think of starting antiviral on OPD basis. And in those children also we don't need to test. We can start directly antiviral if we are very sure that this is viral flu-like illness, and this child will need antiviral so that his duration of illness, his duration of what you say, the all these symptoms will cut down. If you start early, the total duration of illness will come down. He will get better earlier. So for OPD basis, there is no need to start, no need to investigate like throat swab. If you are having a child who is indoor, yes, in those patients you can send the throat swab. Flu panels are available. Now there are multiple panels. There are bigger panels are available like BioFire, upper respiratory panels. These are larger panels. These are costlier panels. Now there are some flu panels are available which test common 4 or 5 viruses like corona, influenza, parainfluenza, and this human metapneumo and RSV. So these smaller flu panels are also available, which are cheaper and which can be used in IPD basis.
Right. So this is very important. So particularly when the results of these tests are likely to change the management. For example, use of oseltamivir in management of influenza, or if there is a severe disease or an ICU admission, or if the child is in the high risk category, like particularly children under the age of 2 years, or with chronic heart disease or a chronic lung disease or some malignancy, or a child who is on long-term steroid therapy, then one should be aware that diagnosis of the virus is very important, because probably the management may change. And if it turns out to be positive for influenza, it's possible that we'll have to use oseltamivir. Let's come to another case where this is a child who is 3 year old. He visits the emergency room at 2 in the morning with history of sudden onset of breathing difficulty, preceded by history of mild cold and fever. Okay, so earlier he had cold and fever, but now he has come with sudden onset of breathing difficulty, and he is restless. But when the parents comfort him, he is comforted. There is audible stridor, the inspiratory sound, and the stridor is at rest. It worsens while crying, and there is minimal intercostal retraction. The heart rate is 120, the respiratory rate is 26, and the saturation of oxygen is 92%. Okay, so this child has been diagnosed to be a case of croup of moderate nature. So, Dr. Keyur, will you like to just tell something about this entity called croup?
Yes, sir. Croup, also we know as a laryngotracheobronchitis. Why there is a typical sound like a barking like cough? Why it happens? Because there is a swelling on the vocal cords. So due to that, it happens. Then why the inspiratory stridor? Because again, during inspiration, the child has difficulty in breathing and that makes sounds. So these barking cough, inspiratory stridor, hoarseness of the voice, all these symptoms are coming due to the edema of upper respiratory tract. Now, what is the so? Just 1 second. Am I audible?
Yes, yes.
Okay. So why these symptoms of so the most common cause of croup is viral infections, as we know. So mostly para-influenza viruses are very common, and other viruses like RSV, influenza, adeno, they can also come as a croup. And so but the most frequent culprit is para-influenza virus. So for these, we need to treat them symptomatically. We need to manage their airway first. We need to see how they are breathing, whether there is any difficulty in breathing. If difficulty in breathing, we need to start treatment to reduce the edema. So the first and foremost treatment part is how we can reduce that edema, which is causing the hoarseness, stridor, and everything. So here comes the role of steroid. Again, as sir has shown, it is divided into mild, moderate, severe. And depending on that, we can decide whether we can treat him on OPD basis, whether we need to admit him, whether he will need adrenaline nebulization, whether he will need IV steroids, and everything. So yes, so as rightly said, we need to see the how his airway is maintained. So the first priority is to maintain his airway and manage his airway. So if the child is mild, we can observe in ER and see whether he is worsening or not. If he is not worsening, then yes, we can send him home. If it is worsening, we need to admit him. And yes, the first line of treatment is steroid. If not given before, it can be oral, nebulized, intramuscular. If it is severe form of croup, we should go to the first dose of intramuscular steroid and with nebulization of budesonide. And nebulized adrenaline is the part of treatment, but the racemic mixture of adrenaline is usually not available, which is required actually for this kind of treatment. But what we do is what routinely available adrenaline we use. So it may not be as effective as the racemic mixture of adrenaline, which is actually indicated, but still we use it. And but while using adrenaline, we need to see that because you are using routine adrenaline, which is available, we need to monitor heart rate. Because if we keep on giving adrenaline nebulization, it will shoot the child's heart rate more. So that has to be monitored. And again, it depends how the child progresses. We need to manage him. So sir has rightly given the doses of nebulized budesonide, oral or intramuscular dexamethasone. And again, if the child is stable, we can shift to the oral prednisolone also.
Sure. So that's an important information that Dr. Keyur has given us. So remember, when a child like this comes in the OPD, it's very easy to diagnose these children because there's this typical triad of inspiratory stridor with barking cough and change in voice. And now we have understood that these symptoms, and particularly the change of voice and barking cough, they are all related to larynx. This is laryngotracheobronchitis. So the voice changes, and these are all viral problems. But the treatment that we are giving is not in the form of antibiotics. We are giving them steroids and adrenaline because we want to reduce the swelling, the edema, and all. Remember, because these are viral problems, and we want to avoid some serious problems cropping up in this particular child. So remember that one has to be careful in some of these viral infections, and particularly when you come across these children, it's very easy to diagnose in the OPD. Even if you are sitting in your chamber and outside these children cough like these, then you can always see that they are taken up first before other patients, and then they are treated appropriately. Okay. Now, Dr. Keyur, why do you think that these viral respiratory infections that we have been discussing till now, they present so differently in children, as compared to adults? What do you think are the major differences, in children as compared to adults, which make those presentations so different in pediatrics? What do you think?
So it is because the how the immunity. So see, when as the age advances, our body gets trained to handle different types of infections gradually. Whenever any infection happens, our body gets trained. So because what we can see that the most viral infections are the frequency is during up to 5 to 6 years of age, and later on gradually the frequency reduces. So that is the most important part. The body gets trained
Right,
as gradually we child acquires any infection. And
right,
second thing is that immune system is still developing. Okay, and in the earlier age group, children are more exposed because they are going to daycare, or they are going to schools. So they are more exposed because they are more together. As the age advances, that the schooling, the daycare, that frequency also reduces. So they get more infections due to higher exposure also. And then there are behavioral factors, like because the hygiene, frequent hand wash, not touching the face, not touching the nose. So these factors also uh, matter, because so these are the development of immunity,
sure,
high exposure during daycare, preschool, schools, then behavioral factors. So
right.
these things matter, but as age advances, then the frequency reduces.
Right, right. This is important because many times, parents keep asking us as to why my child is getting, these problems repeatedly. So you can tell them, as we discussed in the beginning, and Dr. Keul told us that during COVID, children did not develop that much of immunity against some of these viruses. So you can tell the parents about this aspect, non-development of immunity during COVID. You can also tell them about the smaller airway caliber of children. The airway is small, so they get problems which are much more severe. So there are some host factors also, like for example, if the child is premature or malnourished, or he has some comorbidities like congenital heart disease or some other problem, then it's possible that the child gets frequent respiratory infections. And we have seen in practice that the same virus can cause mild upper respiratory infection in one child and severe lower respiratory infection in other child. So these are all factors related to the host. That means the child. As I said, maybe a malnourished child or a premature child or a child with comorbidities. So it's always important that you know these facts so that you can explain to the parents, and then they usually are satisfied. Otherwise, they keep shopping, one doctor to other, and they are never satisfied. So if they get a proper explanation, then usually they will be happy. Okay. And then we'll come to this case, a 7-month boy brought with increased respiratory movements, difficulty in feeding for a day, and the child has preceding history of runny nose and fever for a day or two, and this child has tachypnea, retractions, wheezing. Okay. And this has been diagnosed as bronchiolitis, which is the pulmonary infection of young children characterized by wheezing. It starts as cough and coryza, leading to respiratory distress in 2 to 5 days. And the child can have fever and tachypnea with wheeze and prolonged expiration. Okay. And these are the children where you have to watch for apnea, you have to watch for dehydration, you have to watch for respiratory failure. So, Dr. Keyur, will you like to speak a bit about the causative organisms and the managements of such children? Yeah.
Yes, sir. So the most common cause of bronchiolitis is the bronchiolitis is basically viral infection. The most commonest organism is RSV virus, and after that, then come the other viruses like human metapneumo, rhino, adeno, as you have seen. But the most common causative viral infection is respiratory syncytial virus. And what
Sure.
we see is that the children who were preterm, who were low birth weight, who are malnourished, so they are more prone for this type of acute bronchiolitis like infections. So the treatment is again supportive because this is the viral infection. As we know, there is no role of antibiotic unless and until we are thinking of any secondary bacterial infection. But the primary treatment is supportive. We have to maintain hydration, you have to maintain oxygenation, and you have to watch for the respiratory distress. And according to the respiratory distress, you have to supplement the oxygen, and different oxygen delivery systems are there. So the role of bronchodilators, hypertonic saline, nebulized adrenaline, these are all discussed very much, whether they are actually useful or not. So there are different studies which shows that yes, hypertonic saline is important, useful. Some studies says that this is not useful, but everything is managed. The main important is hydration, oxygenation, and supportive care. So that is the most important for us.
Right, right. And I remember, right from our residency days, we have been hearing that for bronchiolitis, no ABC, antibiotics, bronchodilators, and corticosteroids, never to be given,
Yeah.
not required, because it's a viral illness, so antibiotics are not required. And oxygen and hydration, these are the only two important things. And we have to see that the child is properly oxygenated, and it is important that you monitor oxygen saturation very, very, very carefully. It so happens that sometimes these children, they suddenly worsen. And during last so many years of our practice, we have seen that sometimes, even in hospitalized children, this oxygen is disconnected simply because child appears better, but again after some time or maybe by evening the child worsens. So we have to be very, very careful. Monitoring is extremely important, otherwise children can suddenly worsen, because there are plenty of secretions in the chest because of these RSV, these viruses, and these secretions, they do not come out so easily. So there is edema of the, mucous membrane. There are those secretions. In about 30% children, there is also spasm, and there are so many problems, and the small caliber of the airway. So all these problems, they come up together. These children really, need to be observed properly. Of course, majority of children with bronchiolitis, those who are in the mild category, they recover. There is no major problem. But in the children who land up in serious problems, they need to be monitored properly. So in general, there are some core principles of managing viral respiratory infections, of which the supportive care, which we discussed till now, in the form of hydration and giving paracetamol and oxygen if required, they are very important. We have to avoid unnecessary medications, and we have to monitor for complications, and educate the parents about the natural course. And most important is that tell them that these viral infections are self-limiting. Now, it's important to understand certain things about influenza, and it's important to know as to how it differs clinically from other viral respiratory infections. As I told you in the beginning, there are influenza-like illnesses, and influenza is the father of all influenza-like illnesses. And these are the children who come with severe, headache. Actually, the onset could be with high fever with chills, and then the child can present with headache, pain in the muscles, weakness, and once they come to the OPD, if there is epidemic of influenza around, and there are quite a few children coming to the OPD, and you have seen certain children getting tested and positive for either H1N1 or H3N2, it's prudent and wise to put these children on oseltamivir. And influenza is one of the viral infections which is eminently treatable with oseltamivir. It is known that these are the children who recover faster. It reduces the severity once we use the oseltamivir within the first 48 hours. And even if the child comes little late, maybe on day 5 or 6, even if you start oseltamivir little late, the seriousness reduces, and the rate of hospitalization reduces, and also the mortality reduces. During the pandemic of H1N1 in 2009, we had different centers from our country reporting the utility of oseltamivir, even after 5 or 6 days. So remember that when you suspect influenza, it's always prudent and wise to start oseltamivir fast. Even the WHO guidelines for the therapy of influenza say that you need not wait for the report of, the nasopharyngeal swab and to see whether this child has H1N1 or H3N2. It's better that you put this child on antiviral like oseltamivir, because this is something which has to be used before 48 hours. And it's very important that you reduce the severity of the illness and the chances of hospitalization and mortality. Dr. Keyur, will you just elaborate a bit about children who are at a higher risk of severe influenza, which you come across in your practice?
Usually, children who are less than 2 years, we need to monitor them very carefully because the parents usually miss the progression to severe illness because they cannot the child cannot complain. Then the parents need to actively monitor their respiratory rate, actively monitor their hydration, everything. So children who are less than 2 years of age, then children who are having predisposing premorbid condition like congenital heart disease, any chronic lung disease, or children who are on immunosuppressive therapy, so like they are on prolonged steroids or chemotherapy. So these children are to be carefully monitored. Again, children who are having very high grade fever, those who come with 102, 103 kind of fever and poor oral intake, poor hydration. So these children are need to be monitored because they may progress to the severe, like low respiratory tract infections. So these children need to be monitored properly.
Okay, thank you. And then, of course, one should be aware about the preventive strategies which are most effective in reducing the viral infections. And these preventive strategies include hand hygiene, particularly the medical fraternity. When we come across so many patients continuously in our OPD, it's important, that you wash the hands frequently and in between two patients, because the transmission of some of these viruses is through fomites. Okay, these viruses, they sit on the tabletops, laptops, handkerchiefs, and it's important that we prevent the transmission at least from medical fraternity to the healthy children. Okay, and we have to follow the respiratory etiquette. Also, teach the parents to teach the children so that children learn to cough in the elbow. And also remember that in case if you are sick, or if you find that there is someone who is sick, it's better to be at a distance of at least a meter, hands distance from others, so that the transmission possibility is reduced. And it's also important that the child receives breastfeeding in the first 6 months exclusively, and the nutrition remains very, very good, because most of these illnesses, if the child is malnourished, can worsen. Okay, so just remember that most of the viral infections basically are benign and self-limiting, but clinical vigilance, rational testing, judicious antiviral use, antibiotic stewardship, and strong preventive strategies, particularly influenza vaccination, are essential for improving the outcome in pediatric practice. Dr. Keyur, in case if you have something which you would like to convey to our listeners, please go ahead and give your final comments about the viral respiratory infections.
So we need to remember that 80% of our patients in our OPD are of any upper respiratory tract infections are viral infections. And if we are writing 80% of patient antibiotics, then we are doing something wrong. So we need to have audit ourselves that how many percent of patients with upper respiratory tract infections we are writing antibiotics. Okay. Even though if we are writing antibiotics for a right patient, remember that the duration of antibiotics many times, because it is habit to write 5 days. Yeah, it is the habit of our hand, just multiplied by 5 days. So if you are giving antibiotic and if you are thinking this is upper respiratory bacterial infection, then please give it for proper duration with proper dose, if at all you are giving. So most of the complaints are parents, so doctors say ki amoxicillin, amoxiclav causes diarrhea, and we need to give some like probiotic with it. So I must say that I don't face much of the problem of diarrhea with amoxicillin or amoxiclav. Why? Because if you write it in viral infection, you will get definitely diarrhea. So if you are having significant complications of diarrhea with amoxiclav or amoxicillin in your OPD, that means you are writing it for viral infections also. That's why the number of diarrheas are. So, so you need to have audit of your OPD prescriptions to see how many percentage of people with upper respiratory tract infections you are writing antibiotics. And if possible, you can curtail down, please curtail down, because we all know that we are having such a high rise of antimicrobial resistance. So that is the message I want to give, sir.
Thank you. And I can say that in corporate setups these days we have what are called as standard operating procedures or SOPs. Similarly, for ourselves, we must learn to train our own minds. What is that training? When a child comes to you with fever, see whether it is viral or bacterial, because most of the fevers are infectious. No doubt there are non-infectious causes of fever also, but they are not so common. So whenever you suspect infection, see that it is classified into viral or bacterial. Okay, but remember, if you feel that it is viral, then don't go to prescription of antibiotics, as Dr. Keure has said. If it is viral, think whether it is a mild viral infection or whether it is influenza. So bring that influenza in your protocol because it's a treatable condition, and then think whether you need to give oseltamivir. Also look out for seriousness of infection, guide the parents to come back, and I always say that do not charge the parents for their first follow-up. This is because when the child is brought for the first follow-up, you are learning. You know what happens to the viral infection after 3 days. Whether this child who started with cold and cough and coryza and conjunctivitis develops rash on day 4, which is because of measles. You know whether this child has worsened and the fever has not yet gone down, and this is a case of influenza. You know whether he is developing, some other, complication related to adenovirus. So when the child comes for follow-up, you are learning. So please develop, a standard operating procedure like thing in your clinic. Train your own minds to classify into viral and bacterial. But if you are unable to decide, don't jump to antibiotics. Also remember that there are viral infections and which also may need treatment. As for example, we discussed about influenza. So some of these things, in case if they are clear, then I think our management would be much more rational, and the what you say, the purpose of today's program will be served. With that, I stop sharing the screen and hand over the proceedings to Dr. Prashant. Thank you.
Thank you, sir. Thank you very much. Thanks, Dr. Kaur, for your inputs. Thank you, and thank all the audience who took time and from their busy schedule and attended this webinar. Thank you. Thanks once again, IT team of Hitro, marketing and sales team. Thank you very much. Sir, you can log off, sir. Wish you a very
Thank,
good afternoon. You can sign off.
thank
Thank
you.
you.
Dr.
Thank you very
Kaur,
much.
thank you. You can sign off.
Thank you. Thank you.
Thank
Thank
you.
you. Thank you. Okay. Wish you happy Sankranti, Dr. Prashant. Okay.
Thank you. Same to you,